Good evening and welcome to our AAIP treatment planning webinar. Tonight we're going to talk about planning a case, and Dr. Sheldon's going to work through that case like he does every single day, and then I'm going to talk about the financial end of it and how we gain approval for that. But before we get started on that, I wanted to remind you we are approaching our new season in July. And we, again, are very excited about our new season. For one reason, the other day, Monday, we spent over 5 hours doing some recordings to get started for that new season. And we're gonna focus a whole lot on marketing because we have had a lot of those requests from everybody, and we feel like we haven't done it in a while. So we're gonna do a lot on that for you. So any questions on that, of course, you can email us as always. We are going to be taking off tomorrow to visit a perio group in New Jersey. We're going to do a lecture for them. A bunch of them have gotten together to share one room and have us speak to them and their staff regarding some of our AAIP strategies and programs. So we are pretty excited about that. So tonight we have the treatment planning session.
The treatment planning session. Let's talk about the treatment planning session. So tonight we're going to talk about a cosmetic case, and let's go through it. And I will, I may be a little bit controversial here. If people want to ask questions at the end, I'll just leave a little bit of time for questions. Usually we don't get questions, which is okay. But if people want to ask questions as to why I said this or why I said that, it's fine. So we'll leave space open. So let's talk about this case. So here's patient calls, and Jennifer gets the call. Patient's referred by magazine mail. That means that the magazine was sent out by every door direct mail. We send out 4,000 copies of our magazine every single week. Eleanor, my wife Eleanor, is in charge of that, and she selects the mail routes, and she has somebody make the deliveries. And so 4,000 magazines go out, 16,000 a month. That becomes a major source of referrals for us. And she'd also talked to friends, and she heard that I knew something, which is nice. Patient has receding gums and perio, is what Jennifer says. Jennifer reviewed the treatment costs as to what they could be and told the patient about financing companies. The patient really appreciated this. Explained the $79 consultation, scheduled me to call on April 4th. And the patient is scheduled on 4/19, and her husband is also scheduled. It's always nice if you get 2 for 1. That's really good. So, we're talking about marketing costs, and marketing costs are reduced by half when you have 2 patients with 1 magazine. That's really great. So I did the doctor phone call and found out that she'd had 1 tooth fixed in Satellite Beach. That's a location right around here in Melbourne. About 25 years ago, and now it's getting worse. And I had her gums fixed on 1 tooth, and it's getting worse. And so based on that, we talked about the fact that sometimes diminished bone is what causes relapse of soft tissue grafts. I wouldn't know, but we'll take a CT scan and we'll be able to see what the underlying bone structure is. Again, we're looking for differentiation. That's differentiation. And those of you who have heard us talk about this, yes, the CT scan is extremely important, not just as a sales tool, but as a diagnostic tool. So then the assistant notes, Joy saw her, and she writes down what you're seeing right here. And she talks to the patient and relates again what's already been written and what we already talked about, so the patient knows that we're communicating with each other. So Joy says, patient presents today, see what her options are for treatment. And this is what the patient would like. She'd like a prophy. She'd like to take care of recession. She'd like to bleach her teeth. And she wants to replace the missing tooth on the upper left side in number 14. So now the patient has given Joy some additional information that she didn't give to Jennifer and she didn't give to me. And her last dental visit was 5 years ago. So more information, and understand now we're not talking about recession. As soon as she says she wants to bleach her teeth, then we're talking about a full type of cosmetic case. So understand, we're getting what the mindset is. And we'll talk about how the cosmetic case um, impacts us, and how as periodontists we can help not only patients but referring dentists. Okay, so then this is the basics. She was referred by the magazine Mail again. Medical history, she has headaches, has receding gums, and she doesn't like the color of her teeth. So now we're seeing more and more in the cosmetic realm as to what would be going on here. Remember, patients want four things. What do they want? They want to smile, they want to chew, they want to be free of pain, and they don't want their mouths to stink. Okay, so those are the four things. And so what does this patient want? She wants to smile. Okay, we're going to go over the awareness characteristics, and we'll present that a little bit today, although frankly, the patient already had her own level of awareness. She already knows what she wants. If she knows what she wants, you don't have to use the awareness characteristics. You can talk with the patient. We're not trying to talk the patient into something and getting the patient to realize something. The patient already knows she doesn't like the way she looks, and she wants to improve it, so we don't have to go through all of this. Here's periodontal probing. I think you'd all be pretty happy with that, but you'll notice there's quite a bit of recession as indicated on the probing. And let's take a look at some of the graphics here so you can get a better idea as to who she is and what she looks like. All right, so let's go through the radiographs, and we'll go through the bite wing, and you'll notice tooth number 3 is kind of bombed out a little bit, and that's a concern. She didn't even realize that. I just saw her today for the first time. She didn't even realize that. So she said, oh, yeah, I guess there is something there. Okay, as we go through here, you'll notice a few things, but she has a missing tooth here, and she'd already identified the number 14 is missing, and she's concerned about that. Here are the PAs. Okay, periodontally, everything's looking good, right? Everything looks fine. Everything is beautiful. Now you'll notice there is an occlusal restoration that needs to be done here. And there's also one that needs to be done on tooth number 31. And that is part of our treatment plan. That's part of the treatment plan that we present, because we're presenting the whole treatment plan. Why? Because the person who presents the treatment plan is considered to be the director of dentistry in the patient's mind, even if the restorative treatment is being done someplace else. What you've identified and what you've sequenced as part of the treatment plan puts you in the position of director of dentistry. Let's look at some photographs for a second. Okay, so we'll look at the straight-on shot and take a look at this. What do you think about that? What do you think about this? Is she a left-handed brusher or right-handed brusher? Can't tell from these pictures. She happens to be right-handed. Notice she has good gum tissue right here and doesn't have nearly the same level of erosion, or perhaps a little bit of abfraction, not much. Notice good gingiva here. Notice this. Not much keratinized tissue there, and you've got that that buccal frenum that's right adjacent to the tissue. Take a look at the cervical lines here. Okay, so you get the idea as to what's going on. Next photo shows you about the same thing. Now the teeth are in occlusion. See what's there. Okay, now let's take a look at the smile. And really, with this smile, it's really unaffected. But I want you to look at some other things that are going to be more important in the treatment plan later on. In fact, not just later on, right now. Remember, she wants to have her teeth bleached, and she wants to be able to smile better. With photographs that are projected up here, if I can say, okay, I understand when you want to smile, let me give you my observation here. See how this tooth is tucked in so nicely right here? Look at this tooth and how this tooth is sticking out a little bit. See this space here? All of that is part of the smile. Let's take a look at how the buccal corridor is filled on the right side. Now contrast that to what's going on the left side. You see how there's a black space over here, but this space is filled. That all has to do with your smile. And we can start to educate the patient as they're looking at their smile, because um, this is something that allows the patient to know, as you're giving the patient an idea and kind of a little bit of a mini lecture as to what the smile is all about, what the construction of a smile is, how a person will look, then the patient, again, is taking instruction from you, and chances are is hearing things from you that she has never heard from any other dentist before. Because now you're looking at the whole patient, not just the gums. We're looking at the whole patient. And the patient, particularly when she's already identified that she wants to be able to smile well, now if you're showing her that you know how to construct a smile, even if you're not going to do it yourself, again, you're the authority figure, you're the source of information. Well, I can show you the mirror shot, but I think you get the idea as to what's going on here. And this is the right side, so this is the mirror shot of the right side. Okay, so keratinized gingiva here, almost gone, and certainly we've got a very high buccal frenum. By the way, that's not going to influence my initial treatment plan, and people are going to question my initial treatment plan. I guarantee you are, which is okay. Okay, so that's what we're looking at so far. Let's look at something else that may be a little bit more educational. Again, if you have the CT scan right in front of you and right in front of the patient, there are things that you can do to educate that patient. Remember the area where you saw that erosion, where you can tell that there's recession, there's erosion? I want you to take a look at this picture right here. This is the nerve of the tooth right here. Do you see how deep that erosion is? It's almost on top of the nerve. Your teeth a little bit sensitive? Yeah, they're a little bit sensitive. Yeah, they are. We can see how deep that's gone. And this starts to ring home a little bit as to why the patients are having sensitivity. Everybody wants to know why. You want to know why too. You know, if you have a medical problem, you feel a lot better once you have identified the why. And if you can create the why, really giving instruction, showing the patient, let's take a look at the next tooth over. Well, look at this. Here's the nerve of the tooth right here, and look how deep that erosion goes. It becomes a problem that really needs to be addressed. Even this tooth here. Now the patient starts to be able to read it. Now you've shown her one or two. Now she can see her own notch and see how it is. Oh, what's this over here? Yeah, that's the nerve over there too. Okay, I don't want to belabor the point. Let's look at the left side. And on the lower left side, we're going to see a notch, very small notch on tooth number 22. But now you go to number 21, and now the patient can see how serious a problem this is. It's not just a cosmetic problem anymore. It's a potential health problem, or at least not a potential dental problem. It is a dental problem. And we all talk about how we could treat this. And while we're doing that, we can certainly now educate the patient on the fact that she is missing a tooth right here. And yes, a dental implant could be done. And you know, you're really, really fortunate because you have a little bit of bone. This is your sinus right here. Here's the bone below the sinus. Let's measure the distance between, or the amount of bone that you have from where the implant would go in right to the sinus. And right to the tip of the sinus, we've got about 7.5 millimeters. That's a very short implant. We may be able to use a short implant in there, or we would just bump up the sinus a little bit so we can give you a larger, more substantial implant. Okay, if you take a look at this as we go across, I want you to notice something else, and that's this. Let's take a look at the profile of the bone. This is your cheek over here, and we're looking at the tooth right in front of the space. Now what I want you to do is look at this profile, see where this is, because you'll notice the root sticks out a little bit. Let's move the CT scan a little bit towards the space where you're missing teeth. There it is. You see how the bone has come in? There's a little bit of a divot there, and that means that, and you can feel that divot. Just put your finger in your mouth and you can feel it. You feel how that's sunk in right in that area, and the patient will put her finger in that area. Okay, we need to build that divot out. Otherwise, the tooth is going to look a little bit funny. It's going to be overhanging your gum. And it's going to be very, very difficult to clean. Okay, so now the patient can feel with her own finger after she's learned how to read her x-ray as to why you might have to do a buccal ridge augmentation. Now she understands the reason for sinus lift. All part of this instructional process. Okay, so now let's move, and you'll see as we go back to the molar, to the second molar, how the ridge comes out again. So you can see your own divot right there. See that? Good. Just in Augusta, Georgia, they're talking a lot about divots there. Had a good time with the residents at Dental College of Georgia last week. It was really good. In fact, I think one of the residents is on this call tonight. By the way, if you know residents get into the AIP, can listen to any one of these webinars at no cost. So you get the idea. Now let's take a look at it. And again, you may say I'm belaboring the point. Oh, I put this implant in here. Let me take that implant out. But patients like to see this. Patients love to see their own mouths. They're seeing technology they've never seen before. Well, let's take a look at what those divots really mean to you. You see that? Now you can see how deep that really is. You can feel that with your fingernail. You can see how deep that is. So we don't want to get that to get any deeper. Now you're talking about restorative dentistry. You may want to build that area out and place some filling material in there to prevent that divot from getting any deeper. I'm going to show you what we're intending on doing, which will be a little bit different from that. But again, now you're seeing, and the patient can really, really, really see the problem. I don't deviate from any of this. I don't go to my long-winded explanation. I'm probably giving you too long-winded an explanation right now. But what I do is let the patient see it in pictures and describe the pictures well enough the patient can really identify. And of course, I'm doing it also with the financial arrangements assistant, so that if Danielle is the FA assistant, she's going to carry this right into the FA room, because she can then say, remember Dr. Sheldon said, you see what's going on here? See how much damage is occurring here? All of those things are carried on from my examination, which only takes, in this case, maybe 20 minutes or a half an hour, to her. Okay, let's take a look at another thing. Remember we talked about smile and how smile is important. So this is SNAP. You've all seen SNAP before. Okay, how many of you think that we're going to be able to bleach these areas successfully? This isn't a brown stain. These are gray teeth. So are we painting the case that maybe veneers are ultimately going to have to be done? I think so. So we can show her what she could look like. And now she gets a better feeling. Here's the buccal corridor here. Okay, let's fill the buccal corridor even more on the right side. But look at what's happened on the left side. Okay, where these teeth are bent in, now they're straight. And now we can see how we fill the buccal corridor and how that smile looks that much better. There's an example of how we can use the SNAP, which essentially takes, if we're really spending time with this, it takes us maybe 5 to 7 minutes to get this arranged, selecting the correct tooth, and then changing the curvature of the smile in such a way that it conforms with their lips. It's very easy. The SNAP program is the easiest program, easiest imaging program I've ever seen. There may be others out there, but the SNAP has been very, very successful for us. So you get the idea as to what's going on. Now let's go back to the patient's photographs for a moment. And again, I want you to see this because you've got quite a bit of recession here. And notice the tissue is very, very weak here. In fact, this muscle attachment is pulling this tissue down. I know it's not a muscle attachment. But we can see what's going on here. Now, to my way of thinking, I would rather build up the tissue here and get as much coverage with tissue first and then build out the rest of it if we need to. So my goal in therapy is to do a gum tissue filling. I want to cover those roots with gum tissue as well as we possibly can, and that's that. And so we work on the soft tissue first, and then we fill in whatever defects are left with filling material if we need to. But if we're able to replace the gum tissue, if we're able to move that gum tissue up even 50% of the way, we're doing you a much bigger favor, and we might not even have to do fillings in those areas. And of course, now these areas are going to be protected by gum tissue, and as long as we're helping you brush correctly in those areas, that could be a very good and easy fix for you. Okay. And I'm saying that in every single area, even though we've got great keratinized gingiva here. Anybody going to have any trouble getting full root coverage here? I don't think so. Okay, we can question it here with all of this going on, and we can even question it here. But look, we've got interproximal tissue no matter where we go. Patient has no periodontitis, has no black triangles, and therefore the opportunities for at least root coverage, I'm not talking about abfraction coverage, root coverage are very, very high in a circumstance like this. Well, we've got to understand what the patient's priorities are first. The patient's priorities have to be health priorities. So we've already identified that the patient has decay on tooth number 3. That's got to be taken care of before we take care of gum disease. Okay, so we're going to work with our restorative dentist. I'm fortunate enough to have my son right here. You are fortunate enough to have top-level referral sources that you work with, and these are the doctors you want to work with, always working with the A doctors. And so the first thing we do is clean your teeth. It's been 5 years since you've had any dental care. Let's clean your teeth first, and then we're going to refer you out. And here's what the dentist is going to do. Likely we're going to be doing some restorative dentistry. That tooth may need a root canal, may not, and your dentist is going to do everything he can to prevent the need for doing a root canal. And Danielle's going to explain that a little bit more to you further. And then there are a couple more fillings that need to be done, and then we'll do the crown delivery. And then we're going to do the bleaching. And it'll take about 2 weeks with standard bleaching trays for us to see the maximum effect of the bleaching. To me, that's up to you. If the patient has seen you first, remember, it's your patient. It's the biggest problem I had in orientation after we were referring directly, or after we're getting patients directly from the street. I still thought it was a restorative dentist practice. Remember?
Mm-hmm.
Remember when we went through?
Oh, yes.
And we had one restorative dentist in particular who said, "Yeah, of course it's my patient, even though you referred him to me." It's horrible. And then he would tell the patient, you don't need to see leave for cleanings anymore. I can take care of everything. Yeah. So then bleaching. Okay, so now we address the cosmetic need, and we say, I don't think bleaching is going to carry you all the way, but let's see how far the bleaching will take you. Okay, then we'll do the soft tissue graft, upper and lower. In this case, I would use pinhole. This is full mouth case, and I would use pinhole in a case like this, and I think the results will be quite good. Okay, then we'll reevaluate for restorative dentistry. Who's doing the reevaluation for restorative dentistry?
You are.
I am. Lee Sheldon, periodontist. I'm doing the reevaluation for restorative dentistry. Why? Because I want the message coming from me. I've done the pinhole. I know 3 or 6 months later how successful the pinhole is, and now I can give the patient instruction or my advice as to how the fillings should be done and where they should be done in certain areas. Now, if you have agreements, good agreements with your referring dentists, they'll say, yeah, thank you for settling that case. There'll be others that say, no, I want to make all the decisions myself. Well, you'll have to decide whether that's the doctor that you want to work with or not. And by the way, every doctor that we work with has the right to call an audible, just like we have a right to call an audible with regarding periodontitis or dental implant therapy. Okay, then reevaluation for restorative dentistry, and that would what I didn't write down here, and I forgot to, is on tooth number 14, we'll likely do an implant, okay, which will be partial sinus lift, and it'll be an internal lift. We'll likely use the Versa Densa burrs, and we'll do a slight buccal ridge augmentation using a membrane, Mineros, and PRGF in order to build out that ridge. And I forgot to tell you, Danielle, but now you know. Oh, actually, you know that. I didn't write it down.
Yeah.
Okay, and then restorative dentistry is necessary for cervical margins, and then consider crowns and veneers in the smile area. Now, she may only accept part of this treatment plan, but now she knows the entire sequence. And who did the sequence come from? Me, 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 me. Okay? So important that it's coming, again, I'm pushing this point home really hard because we have to get used to the idea that we are directors of dentistry, and if we get that idea that we are directors of dentistry, then there's no limit as to where we're going to take the patient, and of course we're in charge now of the patient's care. Okay, you have any questions? And by the way, I don't go into this kind of detail. I say, Danielle, I think we're going to use blah, 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 blah. Danielle will explain it to you. The overview is this. You've got disease, we're going to take care of that first. You've got decay, let's get that taken care of. One of these teeth may need a root canal. We're going to try not to do everything we can to avoid a root canal, but I just want to let you know that in advance. There's a couple of fillings you need, and of course we're going to clean your teeth. And then we'll bleach your teeth, and we'll see how white they're going to get. When you have great teeth, they may not get as white as you want them to get, and so you saw that snap. You saw that. Your teeth aren't going to get that white with bleaching. You're going to have to decide, on your own whether whether the bleaching is bright enough for you or not. If it is, then we stop right there, and you'll just continue to bleach periodically. If not, then we have veneers or crowns. They can not only bleach the teeth, but they can also give you a broader smile. Okay, that's a decision we're going to make down the road. Bleaching is relatively inexpensive, and so we can do that first. We have to do that first anyway, so we have nothing to lose. That's the explanation that I give. I talk a little bit about the pinhole graft. We're going to move the soft tissue up. Soft tissue isn't going to cover the entire roots or the entire area of erosion or recession in that area, but it's going to cover a good deal of it, and it's going to give you much stronger gum tissue, which will be much more resistant to further recession down the line. Now, we may not be able to go all the way with it. Wherever we can't, then we're going to fill in those areas with filling material, and we'll talk with you and with your general dentist about that after we reevaluate the effects of the graft. It'll probably be about 6 months after we've done the graft. We'll then reevaluate and decide what the next restorative dentistry procedure would be. Okay. Any questions you have of me? Yeah, how much is it going to cost? Well, Danielle is right here, and she's going to talk about that. Well, what about this little? And at that point, Danielle does.
I think, Dr. Sheldon, they need you in another room. I'm going to go on ahead and take over here with Sue, and I'll be able to answer all her questions. Yet, if we need you, I know where to find you.
Good. Well, Sue, it was great meeting you. And if you have any questions, Danielle can just grab me. That's it. I'm done.
So, as a new patient assistant, I start to investigate my patient the moment I see that I'm assigned to this patient first thing in the morning, because I need to find out what the patient really wants, what she's going to be wanting, he or she's going to be wanting when they come in. And I'm also trying to find out what they're going to be willing to accept and what they're going to be able to start out and do. As much as we from the beginning, a lot of our cases that we have spoken about have been pretty large cases, and we've closed these cases the same day. That's not always our goal. Actually, it's a very good goal, but our goal is not always to close the entire plan all in one day. There are some patients that just cannot happen. There are cases that need a lot of work, and they can start slow. There's some cases that need a lot of work, and there's no option but to go all the way all at once, because we need to get the bite lined up. There's a lot of disease going on. There's different reasonings. For this particular one, from the doctor's note, from the new patient call, the doctor's note, it was very clear that this patient wasn't in an emergency situation. Her main goal was to get established somewhere, and that was really her main want from the beginning. And so in talking with her when she is first seated, we find that out. We find out her concern was to get established somewhere. We find out it's been 5 years since she's been in the chair. She's just trying to get back in there again. She had gotten the magazine, and the magazine, the pictures, the stories is what made her call. So doing this and seeing as when she smiles, she's got a nice smile. She's not a dental nightmare doing the examination with her. There's not any perio pockets going on, but yet you can see and she knows that she does need some stuff done. So what we do for cases like this is we want to build trust. We want to build trust because I know that the moment she starts having treatment in our office, she's going to love us and she's going to want to come back. So we want to build the trust. We want to get her established so she is a returning patient. We want to feed our referral source with some patients so that we are continuing doing that. And we want to give her the entire plan so there's no question, there's nothing left undone, and let her pick her own pace. So for Sue, she had already said right when she had sat down that she did want to have a cleaning number one and then kind of go from there. So when I sit down with her, I'm going to say, okay, so what Dr. Sheldon has proposed as a plan for you is this right here. And I know it looks like a lot, but this is everything that you need to get back into the dental condition that you want again, where you like your smile again, where you feel good again, you're back getting your cleanings done again. So the very first step is to get a cleaning done. It's been 5 years. Come in, get a cleaning done, and get all that behind you. The next thing is to get the restorative work done, which is the buildup in the crown on number 3 with that pulp cap, the pulp cap, and then 2 surface filling on number 30 and a 1 surface filling on 31. Now that we're going to have you go either back to your dentist, or we're going to refer you to a dentist that we work with quite a bit, Dr. Smith, and he's going to be doing all that work for you there. But I'm going to go on ahead and call his office and get you set up for an appointment there and send the x-rays and send this dictation letter so they know exactly what to do, and you're going to go have that done there. You're also going to start, after that is completed, you're going to start some of the bleaching treatment. You don't have to go that route if you don't want to. I know whitening your teeth is something that you had come here for. As Dr. Sheldon said, you're not going to get your maximum goal by doing this. That will come down the road when we look at doing veneers and crowns and such, but you may have some success with this that you're happy with, and that will be able to satisfy you short term. The next step we're going to do after that is we're going to do that pinhole grafting. All those areas where you saw that you had the recession, where you had that sensitivity, where you had those areas that have those divots in that you don't like, all that area we're going to be doing what we call the pinhole graft, and I'm going to do an educational video to show her. I'm going to do some pictures to show her how non-invasive it is, how fast it is, how successful it is with all of our past patients. The pinhole graft, phenomenal procedure. Not very many doctors do it out there. Dr. Sheldon and Dr. Furtado are both certified to do the pinhole graft, and it requires no incisions, no sutures. So we'll talk about that with her. So we're going to have that done, and then we're going to look at replacing the tooth on that left side so that you can have full chewing function in that area. So with that, I'm going to say, okay, Sue, what would you like me to schedule for you now? I've already got you on the schedule for the cleaning. How much more would you like to start with? For her, she wanted to get the restorative stuff done first, and she had already mentioned that in the chair, that that's where she wanted to start, and I actually had the plan broken up like that, so it didn't look like 20 things in a row. It actually had 1 thing, then 4 things, then 3 things, and then 4 things, so it was actually in a phase, looked pretty safe to go on ahead and get started in it. So that's what she wanted to do. So for her, it said, great, here is your appointment for your cleaning. Here's your appointment for Dr. Smith to go have that restorative work done. And here's your appointment to come back after that for the reevaluation, which is also after she's had the bleaching done as well, so we can determine if you're ready for the next step, which at that point will be to go to surgery to do the pinhole graft. And she was so excited to start at that speed, and she was so thankful for all the information, for building that relationship, for not being pushy, for not trying to get everything done at one time, which was completely overwhelming. And for her, it was clear from her and her husband that Dr. Sheldon had said that money was not an option for them. So it wasn't something where we're trying to budget it in from. We're not trying to create an affordable budget. We're trying to create that trust factor. And I think that we did a very, very good job with that. So she did accept today, schedule today, pay today for those 2 phases. And she's going to be one of the patients that continues to come back. Our referring dentist is happy, she's happy, her husband's happy, which will result in more referrals.
Good. And that's pretty much it. And that's how a case like this works. So, you could very well have a patient call and say, do you do cosmetics? Do you do veneers? And what's your front desk person going to say? Whatever your front desk person says determines whether that patient is going to make an appointment with you or not. Remember, we're marketing ourselves as specialist first, or as dentist first, as specialist second, and periodontist third. And marketing like this can bring a patient to you who needs full reconstruction and look at all of the procedures that you have to do. Number 3 could potentially need crown lifting. Tooth number 14 needs a ridge augmentation and a partial or an internal sinus lift and an implant. And look at all of the soft tissue grafting that's there. So we market ourselves as dentists. We provide solutions first, and when we do that, we get periodontal procedures that we can do ourselves. Okay, that's it. We will be back, May 4th?
May 4th, like yes.
All right, good. Well, I said I would take questions. If there are any questions, just raise your hand. And is there a hand raised? Let me see. No hands raised that I can see. All right, good. You are the strong, silent type. Sorry, good. We'll talk to you in a couple of weeks. Bye-bye.
She didn't want you to feel like she wasn't paying attention.